Welcome back to Spill the Health, Real Talk, Real Health. Today we are very privileged to have our consultant, orthopedic surgeon, and also arthroplasty surgeon, our Deputy Medical Director of Beacon Hospital, President of Malaysian Bone Health Optimization Network, and President-elect of Fragility Fracture Network Global, Dato Dr Lee with us today. Hi, Dato.
Hi, Richard.
Okay, Dato, today, we are very privileged to have you here to talk about with us on knee replacement. But before that, I would like to ask you some questions regarding osteoarthritis because I personally have a background in research, especially in osteoporosis, osteoarthritis. So I'm really excited to talk about that. So, Dato, could you give us a landscape of the prevalence of osteoarthritis, especially globally and also in Malaysia?
Okay, sure. Thanks, Richard. It's my honor to be here today to share my view and also some of the information with our Beacon's fans and patients and family about the disease called osteoarthritis. Basically, arthritis means inflammation of the joint, and there are many types of arthritis that we see in the clinic. The commonest one is actually called osteoarthritis, particularly primary osteoarthritis. Primary osteoarthritis means that the arthritis is developed in the individual about 45, 50 years old and above, and common more in female. And that is actually learned in family as well. So that kind of arthritis can affect the finger joint and also the knee, the hip, even the spine itself. So this is the commonest arthritis we see in the clinic. In terms of prevalence, based on the data 2021 worldwide, more than 370 million people are actually suffering from this disease itself. And you're looking at 2021, now it's 2025, so I'm sure that there will be more than 400 million patients affected by this condition worldwide.
Oh, that's a lot.
That's a lot, all right? So it is going to be causing a very heavy sort of economy burden to the healthcare system of all the countries. Particularly in Malaysia itself, we are talking about those 60 years and above. More than 30% of us actually do have knee osteoarthritis, particularly.
That's quite high.
And based on the data, is that the Malay friends and population has the highest incidence of that, followed by Indian and Chinese. But this is only a data that we believe that is might be underreported. And in our practice, we see a lot of Chinese patients also have knee arthritis and so on. So I think this data is definitely underreported. And the magnitude or in terms of severity, the number of cases, the prevalence, definitely higher than what has been reported based in Malaysia and as well as worldwide.
I see. So, Dato, what is basically the main cause of osteoarthritis?
Okay. Osteoarthritis, we are talking about primary, as I mentioned earlier. Primary osteoarthritis are run in family. Like mom has osteoarthritis of the knee or fingers and so on, the primary osteoarthritis, and the chance the daughter has is a bit higher, 2-3 times higher. These are actually running, as I say, familiar and genetically determined. And whereas the other type of arthritis is called secondary osteoarthritis, and means that the arthritis developed secondary to underlying cause. For example, someone who has trauma or fracture involving a knee joint or any other big joint like hip joint and damage the cartilage. We also have the trauma that leads on to the cartilage damage. So that is actually something called secondary osteoarthritis.
I see.
Like gout attack in young men, and when they get age catching up and there are more attack on the knee or the other joint. So that kind of damage can also lead on to secondary osteoarthritis itself. So that's why we divide osteoarthritis to be primary and secondary. But in clinical practice, most of the patients we see are actually belongs to those primary osteoarthritis.
I see.
And that's why when they come to the clinic with knee pain, the first thing we actually assess is actually look at the fingers. Look at the fingers and see the bone spur, they call Herbert's or Bouchard's notes. These are signs of primary OA. And we ask further, the patient will tell you, oh yes, actually my mom had also the same problem. Or my other sisters also had the same problem. All right, so this is actually run in family. And then why am I talking about females, ladies all the time? In fact, the ratio between female and male is about 2-1 to 3-1.
Oh.
So men also get osteoarthritis, but a lot of conditions are actually ladies first. Osteoarthritis is ladies first, Osteoporosis also ladies first.
Is it because female, they will get menopause at their later age, so that's the reason why?
Yes,
Yep.
partly. And some of them, the lady will say that we are doing more house chore than the man.
Oh.
So that's why we sacrifice our knee. And so we actually have bad knee or earlier than men, or more common than men. This is called osteoarthritis itself. Not to talk about other arthritis like rheumatoid and ankylosing spondylitis and all the other gout. These are all big type of arthritis that, of course, not for us to discuss today, beyond our discussion today.
Okay, all right, understood. So at least I believe now the audience, you guys have a bit of understanding about osteoarthritis. So when we talk about osteoarthritis, when a patient come in and see you, Dato, if let's say it's not too severe, then probably we might not need to do surgery. But if let's say if it's really severe, then we need to come to a point that, okay, we need a knee replacement surgery. And for a lot of audience, when they see doctors and then they say, then when the doctor said you need to do knee replacement surgery, a lot of them will be scared.
Yes.
Dato, yes, they are very shocked, and they're worried. I'm 60, I'm 70 right now. Am I okay to do this knee replacement surgery? So Dato, could you explain a bit to us what is knee replacement surgery, how it is done traditionally?
All right. Before that, let's talk about what actually happened in the knee joint.
Yeah.
Like this model shows us that there's a normal knee joint. All right, the thigh bone and the leg bone. And between that, there's a layer of cartilage.
Yes.
And this cartilage is nice and smooth.
Articular cartilage.
All right, I'm sure Richard had this kind of knee. Okay, so this is actually for young people, normal knee joint. But however, some of the 40, 50 years old, they get wear and tear. So basically, arthritis also means that there's wear and tear of the cartilage now. So you can see there's some defect in the joint itself.
Correct.
And particularly nowadays, a lot of 30s, 40, 50, they pick up some game sports that, pickleball, things like that. So they load the knee a lot, then they develop this kind of damage to the cartilage itself. All right? But for those about 70, 80 years old, when you talk about knee surgery, and they belong to this group.
Oh.
So the cartilage is worn out almost completely, and then the spur on the side. And with this kind of arthritis, they find that their quality of life actually affected. The functional status deteriorate. Because they'll tell us, doc, I've been walking crooked, my knee appear like O shape, and then I cannot walk for long, I cannot stand for long. Every step I step on it, I feel the bone grinding on bone pain. And when I sit down to stand up, I can't even stand properly. I have to press on the desk or the armrest before I can stand properly. And I used to go to for tour, overseas tour during Chinese New Year with my family and children. But nowadays, I can't even go for dinner and tea with them because the pain is excruciating. So that's why I actually most of the time get housebound. So functional status actually deteriorate, and the quality of life getting worse. And these are the reasons why they actually end up surgery to change the knee joint. This is something we call knee replacement surgery. So we remove all the damaged joints. They put a metal and plastic set inside there. So after surgery, of course, there won't be any bone grinding on bone, and metal and plastic. So with this kind of knee replacement surgery, success rate is very high. Then they regain the normal functional status. They can actually walk out, they can actually go for a tour, they go for dinner with children, they can travel, they gain back their daily activity, they join their friends, go for like Tai Chi, or the exercise. And so that's what we refer to knee replacement surgery.
I see.
Okay, so in fact, most of the joint, we can actually replace the joint. And joint replacement involves like knee, hip, ankle, shoulder, elbow, wrist, fingers, even big toe. But knee replacement surgery is the most successful joint replacement surgery among all. So it's actually one of the most successful ones. And the success rate is more than 90%, 95% and above. And so that's actually worldwide. You can see that a lot of patients with severe knee arthritis, they go for surgery to change the knee joint, and then they gain better functional status. All right. So of course, talk about surgery, patient wouldn't like it.
Yes.
A lot of them delay for many years. Reason because they're so scared of surgery.
Correct.
They're scared of complication. What happened and belong to the other group, which is actually a complication.
Yes.
And many older patients also, they they feel that, hey, doc, the cost is very high. So they don't want to go for surgery because of financial burden. They don't want to actually cause financial burden on the children. It costs them like 30 over 40,000 a knee. 2 knee might be 60, 70,000. So this is going to be an extra burden for my family. So some of them, they stand the pain. They don't even tell the children that my pain is so bad. But they don't want to cause any burden on the children's financial sort of, status, you see. So these are the two main reasons why they don't go for surgery. You're absolutely right. And so many of them delay surgery until the knee is so bad they cannot stand, cannot walk anymore. Then technically it will be difficult to do the surgery.
I see. So if doctor, just now you mentioned about some complications that the patients are really worried about.
Yes.
So in view of, because I believe that you have been a surgeon for many years, so
I'm quite old already.
You're very experienced, Dato. So from the patients that you have done knee replacement on, like what sort of complications that might happen and how possible it is?
Yeah, good question. Very good question. That's the main
Probability.
worry that many patients have.
Yes.
And success rate, as I say, for knee replacement is more than 95%. There are possible complications. I think the biggest worry is infection. Infection means that after surgery, within the 2 weeks, in a month or two, patient develop fever, and the wound starts to break down, and the whole joint becomes red and warm and swollen, and then patient have fever and chills and rigors, and actually some pus collection in the knee joint. That kind of infection called early infection. The rate, infection rate is might be less than 1 or 2%. All right, so that's one. Secondly, is also some patients develop infection later, many years later, because they might develop some other medical condition like kidney failure, liver failure, and so on. So they might have very compromised immuno status that they have.
I see.
So bacteria sets in, and there's some source of infection from the gum, teeth, lungs, kidney, and so on. Bacteria just swim the blood and go to the implant there. That can actually cause infection as well. But the risk of all those things are actually extremely low. As I say, early infection about less than 1 to 2%. Secondly, the implant is supposed to last for more than 15, 20 years. Some patient implant can last for 25, 28 years. But why some patient develop early loosening? We call it aseptic loosening in medical term. Means that there's no infection, but the implant getting loose too early. Because many of them, they have not been assessed for the bone health. They have not been examined for whether they have osteoporosis. So that itself can actually compromise the stability and how long the implant can stay on the bone itself. Where the implant need to have a bone with a healthy bone mass, bone density, and quality to sit there as long as possible. So that's why very important for those who go for knee replacement, they also need to assess their bone density, whether they have osteoporosis, because they don't want to get this on aseptic loosening, or when they fall from standing high and they hit on the knee, the implant, the fracture happen around the implant. You call pre-prosthetic fractures. After surgery, also they are not encouraged to do that kind of high risk activity. In case they fall, they twist, they might dislocate the joint, which is an artificial joint. And of course, one more important aspect is that after surgery, they make sure they mobilize, exercise the leg, the toes, the ankle early to prevent deep vein thrombosis. Deep vein thrombosis happen because they are resting too long, they do not move the knee, they're scared of pain. So blood gets slowed down in the blood flow in the leg, in the venous system. That can actually cause something called deep vein thrombosis. And deep vein thrombosis can even propagate and get worse to become something called pulmonary embolism. That can be fatal. But overall, look at all these few major issues of the possible complication. The success rate is still more than 95%.
That's glad to hear.
Correct, yes.
Because a lot of our patients, they are so worried about doing knee replacement. So at least today, Dato, you elaborated to us about the success rate and also the probability of some complications, which is pretty low. It might happen, but it's pretty low. And at the same time, I learned something, which is we are not just only to do the knee replacement surgery, but at the same time, you need to take care of your bone health, a good bone density, and at the same time, you need to exercise your leg to prevent yourself from getting DVT.
Yes.
So I think I learned something from you. Dato.
These are the steps that the surgeon
Yeah.
will actually take care of, and those are your therapists will take care of
Mm-hmm.
to minimize all the possible risks. Okay. So in terms of another fear that patients have is that they delay surgery because they don't understand the whole process.
Correct.
They say, after surgery, do I need a wheelchair? After surgery, do I need to rest for the next 3 months before I can stand and
Yeah,
walk?
the
And these are
recovery
all
rate.
completely wrong sort of perception that they might have, because they might be so fearful because they listen to this friend and that friend, he
Correct.
say this, they say that, and that kind of thing. So in fact, knee replacement surgery, after, let's say, assessed by your surgeon, and listen to a story, look at the alignment of the knee joint, get x-ray done, we always do some pre-surgery preparation. For those that have hypertension, diabetes, you normally refer to a physician to optimize your hypertension, diabetes, do a blood test, ECG, chest x-ray. All those are pre-surgery preparation. So that just anything abnormal, their physician has a chance and time to optimize it. And these are again to minimize the risk of any complication during surgery, after surgery.
Wow.
So after that preparation done already, then we'll arrange the day of admission. Day 1, we admit the patient, and the surgeon, the anesthesiologist, will see the patient. Day 2, surgery, and many of them do both knee together. They both, sometimes they actually both knee are crooked. Both knee are crooked means that their knee become like that. You do only one side, that side corrected becomes straight, and the other not corrected but still bent. And they find that the corrected one is longer, so they still limp. So a patient that bilateral knee or both knee affected badly, they will choose to go for surgery both knee at the same time. All right. So day 3, they're actually sitting up, chit-chatting, eating, all these things already. Day 4, they must step down and walk. The physio will see them even though the day of admission to tell them that these are the exercises they're going to do to prepare them psychologically and physically. So day 3, start eating, drinking, all this. And day 4, step down and they walk with a frame. And the frame normally about 10 days. They can even change the stick even for another 10 days. So within a month, either you do 1 knee or 2 knees, within a month you do not need a walking stick. And in fact, some patients 80 over years old, they can walk immediately without even holding a stick on the day 4.
Wow.
Because they are very, in a way, prepared, and they are actually very motivated. They say, after my surgery, I want to move, I want to walk, because I have not been walking and moving for a long time. So with that kind of positive attitude and the motivation, they walk very fast. So traditional knee, we have been doing for many years. So how the knee looks like is actually something like this. That's the bigger model, right? So we actually remove the damaged wound surface already, put the metal, plastic metal, and the kneecap itself with the inner surface are damaged. Then we also change the inner surface to the plastic component. So this one anyway we're doing conventionally for many, many years. All right, and they're very successful throughout the whole world.